Good afternoon, everyone. In the interest of everyone's time, we will go ahead and get started here. Thank you for joining us for our webinar on preventing viral hepatitis among persons who use drugs, hosted by HCET with presenters Ruth Koepke and Kailynn Mitchell. They are also joined by registered nurse Sarah Bourne today. My name is Megan Muhlenbrook, and I am a training manager at HCET, and I will be moderating the webinar today. Let me briefly introduce you to HCET for those of you that may not be as familiar with us. Our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. We invite you to visit our website and follow us on various social media platforms in order to stay up to date with our various trainings and webinars. Couple quick housekeeping things before we get underway. We will be sending an evaluation to you via email after this, and your feedback is greatly appreciated. This webinar will be recorded and uploaded to our website after the fact. So if you would like to go view it, you can visit this and other past trainings on our website. And if at any point you have any technical difficulties, please reach out to us at wisconsin@hcet.org. If you're looking to receive nursing contact hours for this webinar today, you must attend the entire webinar and complete the post-webinar evaluation. There will also be a nursing contact hours form included with your follow-up email that will need to be completed and emailed to Kelly Bradford at the email on your screen, which will also be noted on the form. The presenters today do not disclose any actual potential or perceived conflicts of interest. Throughout the presentation, we invite you to please send any questions that you may have. You can do that by hovering over the chat icon and sending the message to all panelists in the window that appears. We will save all questions and answers for the end, but again, we do encourage you to send them at any point throughout the presentation. So now I would like to introduce you to your presenters for today. So we first have Ruth Koepke, who is the Hepatitis C epidemiologist with the Wisconsin Department of Health Services. Her work focuses on analyzing and disseminating data to inform action to prevent and control hepatitis C and other infections commonly transmitted through injection drug use. Ruth has a Master of Public Health degree in Epidemiology and Biostatistics from the University of California, Berkeley. Before her work on hepatitis C, Ruth worked for the Wisconsin Immunization Program to better understand the occurrence of vaccine-preventable diseases and vaccination coverage in Wisconsin. Before coming to Wisconsin, Ruth worked for the California Department of Public Health on cystic fibrosis, newborn screening, and surveillance for infant botulism. Next up, we have Kailynn Mitchell, who is the Hepatitis C Surveillance and Outreach Specialist with the Wisconsin Department of Health Services. Her work focuses on preventing and controlling the spread of hepatitis C and other infectious diseases related to drug use at community partners and healthcare systems statewide. She also promotes and supports the harm reduction services across the state of Wisconsin as the Hepatitis C Program Liaison to Syringe Service Programs. Kailynn has a Master of Public Health degree from the Medical College of Wisconsin and a Bachelor of Science in Community Health Education from the University of Wisconsin-La Crosse. Before her work on hepatitis C, Kailynn worked for the Wisconsin Immunization Program to implement the CDC Quality Improvement Program called AFIX. AFIX was an outreach effort at hundreds of healthcare provider offices and clinics across the state of Wisconsin that led to increased adolescent and adult vaccination rates. And today, because we have nursing contact hours, they are also joined by Sarah Bourne, who is a registered nurse and epidemiologist working with the Wisconsin Immunization Program at the Wisconsin Department of Health Services, and will be here to answer any additional questions you may have as well. And so with that, I am going to turn it over to Ruth to go ahead and share her screen and start us with our presentation today.
Sounds good. Thanks, Megan. I will just get my slideshow set up. Thanks for your patience. Great, and thank you for that terrific introduction. So you have met met all of us. We will be describing for you some work we've done to help learn how we can all better prevent viral hepatitis among people who use drugs in Wisconsin. So today we're going to start by reviewing some basic facts about viral hepatitis and trends in viral hepatitis occurrence in Wisconsin and the United States. And we'll also review the vaccines that are available to prevent hepatitis A and hepatitis B. And then we will discuss an assessment that we conducted to assess hepatitis A and hepatitis B vaccination coverage among people who inject drugs in Wisconsin. And finally, we will discuss what we all can do to prevent viral hepatitis among people who use drugs in Wisconsin. So first I'll start with some viral hepatitis basics and some reminders. So while the symptoms of acute infection with hepatitis A, B, or C are generally the same, the likelihood of developing acute symptoms varies by disease. And as shown on this slide, the likelihood of the infection becoming chronic also varies by the disease. So hepatitis A infection does not become chronic. Hepatitis B infection can become chronic, and the risk is highest for those who were newly infected. Whereas more than half of people newly infected with hepatitis C will become chronically infected with hepatitis C. Most people fully recover from hepatitis A infection, but severe disease and death can occur among those with underlying liver disease. Hepatitis B and hepatitis C can cause chronic liver disease, including disease that leads to liver cancer and liver failure. And hepatitis C is a leading cause of liver cancer, a leading reason for liver transplantation, and a leading infectious cause of death. Hepatitis A is self-limiting and the care is supportive. There is treatment available for hepatitis B, but it does not cure the infection. And for hepatitis C, since 2013, there are now highly effective treatments available that can cure hepatitis C infection. So that's a really exciting development about hepatitis C. Safe and effective vaccines are available to prevent hepatitis A and hepatitis B, but unfortunately, there's no vaccine to prevent hepatitis C. And finally, I'd like to review transmission of viral hepatitis. So hepatitis A, you may frequently hear about being transmitted through foodborne outbreaks. Hepatitis A is transmitted through the fecal-oral route and can therefore be transmitted through close person-to-person contact, especially if hygiene is optimal. Both hepatitis B and hepatitis C are bloodborne and can remain infectious outside the body for weeks. And as a result of that, these viruses can be very easily transmitted through sharing equipment used to prepare or inject drugs. And today, most new hepatitis C infections are acquired through injection drug use. To varying degrees, all three of these diseases can be transmitted through sexual contact. So with that background information in mind, now let's talk about trends in viral hepatitis. As a result of the ongoing opioid crisis, the consequences of drug use, such as overdose, as shown on this slide, have increased in Wisconsin. And at the same time, infections that can be transmitted through drug use, like viral hepatitis, have also increased nationwide and in Wisconsin. So for example, let's first look at hepatitis C. While the opioid crisis has continued in Wisconsin, the rate of new positive hepatitis C test results among people aged 15 to 29 increased 324% from 2008 to 2018. And this huge increase in hepatitis C among young people in Wisconsin has been driven by injection drug use with shared unsterilized equipment. Now let's talk about hepatitis B. We know that hepatitis B can also be easily transmitted through injection drug use. Increases in hepatitis B among people who inject drugs have been reported in Florida, Kentucky, Tennessee, and West Virginia. And this chart shows those increases in Kentucky, Tennessee, and West Virginia from 2006 to 2013, and it occurred in both urban and non-urban areas. So in Wisconsin, we have not yet observed increases in hepatitis B among people who use drugs. And of course, we would want to prevent that from happening here in Wisconsin. And lastly, now let's look at hepatitis A. Many states over the past several years have reported outbreaks of hepatitis A among people who use drugs, both injection and non-injection drugs. And CDC believes this transmission is occurring through close person-to-person contact among the people using drugs. And this map, which is taken from the CDC website, shows the states that have had outbreak cases of hepatitis A among people who use drugs and/or are experiencing homelessness. And you'll see that Wisconsin, which is circled here in purple, has not yet been affected, but Wisconsin is surrounded by states that have had outbreak cases. So obviously we in Wisconsin want to make sure that a hepatitis A outbreak like this does not happen here if we can avoid it. So thankfully, both hepatitis A and hepatitis B can be prevented by vaccination. And I'm going to quickly summarize the timeline of hepatitis A vaccination recommendations from the United States Advisory Committee on Immunization Practices, which is also known as ACIP. So when hepatitis A vaccine first became available in 1996, ACIP recommended vaccination only for people considered to be at increased risk. And this included people who use injection and non-injection drugs, as well as people who have male-to-male sexual contact, people with chronic liver disease, and children living in communities with high rates of hepatitis A. 2 doses are recommended to complete the series, but 1 dose has been found to be protective in the event of an outbreak. In 1999, this recommendation was expanded to include children living in states, counties, and communities with high rates of hepatitis A. Then in 2006, ACIP recommended universal hepatitis A vaccination for all children beginning at age 1 year. And a universal recommendation means that all people in that age group should be vaccinated, and it's not based on whether or not the person has any risk factors. ACIP also recommended hepatitis A vaccine for children residing in communities with high rates if they had not already been vaccinated. And as a result of the recent outbreaks that I mentioned just a little bit ago, in 2019, ACIP recommended hepatitis A vaccine for persons experiencing homelessness. Very recently, ACIP released new recommendations recommending universal catch-up vaccination for all people aged 2 to 18 years who had not yet been vaccinated. In addition, all persons aged 1 year and older living with HIV should be vaccinated for hepatitis A, and all pregnant women at high risk of hepatitis A or high risk of the consequences of hepatitis A should be vaccinated during pregnancy. In addition, ACIP recommends vaccination for any person who requests hepatitis A vaccination. So now let's quickly review the timeline of hepatitis B vaccination recommendations. Hepatitis B vaccine was recommended by ACIP in 1982. And at that time, it was recommended for just certain groups of people considered at increased risk. And this included persons who inject drugs and people at risk for sexual exposure to hepatitis B. 3 doses are recommended to complete the series. Then in 1991, ACIP expanded these recommendations to recommend universal hepatitis B vaccination for all infants in the US. Thereafter, recommendations were issued to ensure older children would be vaccinated as well. In 1995, ACIP recommended universal vaccination of all children who had not already been vaccinated. In 1997, in Wisconsin, state regulations were phased in, requiring 3 doses of hepatitis B vaccine for entry into Wisconsin schools and licensed childcare centers. In 1999, ACIP's recommendation was expanded to include all children aged 0 to 18 who had not already been vaccinated. In 2006, ACIP recommended hepatitis B vaccine for persons with chronic liver disease. And in 2018, ACIP recommended hepatitis B vaccine for people with hepatitis C infection. ACIP also recommends vaccination for any person who requests hepatitis B vaccination. So then, considering the increase in hepatitis C among young people in Wisconsin, we know that there's a great deal of injection drug use with shared unsterilized equipment happening in Wisconsin. And therefore, many Wisconsin residents might also be at risk of hepatitis B and hepatitis A. So to prevent outbreaks of hepatitis A and B in Wisconsin, we were interested in assessing hepatitis vaccination rates among people who inject drugs in Wisconsin. And we were particularly interested in vaccination rates among adults because many of them missed out on the opportunity to have been impacted by the universal childhood vaccination recommendations that were implemented starting in 1991 for hepatitis B and in 2006 for hepatitis A. So our goals for this assessment were to establish a baseline vaccination coverage estimate for people who inject drugs in Wisconsin. And specifically, we wanted to assess vaccination coverage for sort of narrow age groups of adults in order to identify which specific age groups were most in need of vaccination. We then wanted to use this information to educate decision makers and local partners like you all so that we could to identify methods for improving hepatitis vaccination for people who use drugs in Wisconsin. So moving on to our methods, we identified people who inject drugs using data reported to us through our routine hepatitis C surveillance procedures. And specifically, we identified people who inject drugs from syringe services programs, also known as SSPs, that conduct rapid hepatitis C testing in Wisconsin. Our assessment included people who received rapid hepatitis C testing and had reactive results during January through August of 2018. 11 SSPs in Wisconsin conduct rapid hepatitis C testing and report the reactive test results to us at DHS. Their locations are spread throughout Wisconsin as shown on this map. And for people with reactive results, the SSPs report to us their names, birth dates, other demographics, and risk factor data. So these 11 SSPs are community-based organizations that receive funding from our state health department to conduct HIV testing, counseling, and referral services. And they're not state-run agencies, and they currently do not provide vaccination services. So for people with reactive rapid hepatitis C test results, we looked up their vaccination histories in the Wisconsin Immunization Registry, which is often referred to as the WIR for short. And for those of you who are not familiar with the WIR, I'll give you a little bit more information about it. The WIR was launched statewide in the year 2000. It's always been the immunization information system for people of all ages in Wisconsin. It includes client records for all people born in Wisconsin since 1995, and vaccination information and client information for people born outside of Wisconsin or born before 1995 are entered by multiple sources, including public and private healthcare providers, HMOs, as well as Wisconsin Medicaid. And it's estimated that more than 95% of Wisconsin adults have one or more vaccinations recorded in the WIR. So then moving on to our results. During January through August of 2018, the SSPs reported 215 people who reported injection drug use and had reactive rapid hepatitis C test results. And of those, 95% or 204 people had client records in the Wisconsin Immunization Registry. Among people with client records in the WIR, only 23% had WIR records indicating that they had received 2 doses of hepatitis A vaccine, and 32% had received 1 or more doses of hepatitis A vaccine. When we stratify this by age, in every age group, most people were not fully vaccinated for hepatitis A, and coverage varied a little bit from age group to age group, as you can see here, but some of those age groups had pretty small numbers of people in them, so making these differences insignificant. And this low hepatitis vaccination coverage is concerning because this population is at increased risk of hepatitis A and is recommended to have been vaccinated. Nevertheless, this low coverage among adults is not surprising because hepatitis A vaccine was not universally recommended for children until 2006. And just this year was universal catch-up vaccination of all people aged 2 to 18 recommended. In terms of hepatitis B vaccination, 56% of people had received 3 doses of hepatitis B vaccine. And when we stratify this by age, we see that the younger adults had high rates of hepatitis B vaccination. 88% of people aged 20 to 24 had received 3 doses of hepatitis B vaccine, and 78% of people aged 25 to 29 had received 3 doses. But most people aged 35 and older had not been fully vaccinated for hepatitis B vaccine. And overall, you can see that hepatitis B vaccination coverage decreased with increasing age. And that makes sense in terms of the timing of the hepatitis B vaccination recommendations over the past several decades that I showed you earlier. So like I showed you earlier, universal vaccination of infants started in 1991. Recommendations and Wisconsin school regulations were issued in the following years. So in 2018, when this assessment was conducted, those recommendations would have affected people ages 27 to 37 and younger, which coincides with the trends that we're seeing here. So our assessment has several limitations. For example, vaccinations received out of state or before the WER was implemented might not be recorded in the WER. Therefore, our results might underestimate the actual vaccination rates in this population. However, our results are generally similar to results from national surveys that assess hepatitis vaccination coverage among adults. Also, the people included in this assessment attended SSPs and had reactive hepatitis C test results, so they might have different care-seeking behaviors or have had different opportunities to be vaccinated than people who do not attend SSPs and do not have hepatitis C. Because as was noted in the beginning, having hepatitis C or chronic liver disease are additional reasons for receiving these vaccines. So the people included in this report might have higher vaccination rates than the general population of people who inject or use drugs in Wisconsin. Also, we did not consider that some people might already be immune to hepatitis A or hepatitis B through natural infection and therefore do not need to be vaccinated. But based on surveillance data, that number of people is small. So despite these limitations, most people had client records in the Wisconsin Immunization Registry, and our coverage estimates were generally consistent with national survey results of hepatitis A and hepatitis B vaccination coverage among adults. Our results suggest that even though ACIP has for decades recommended hepatitis A and hepatitis B vaccine for people who inject drugs, vaccination rates for hepatitis A are low for all age groups of adults who inject drugs. And hepatitis B vaccination rates are low for people aged 35. So we in Wisconsin need to work together to improve hepatitis vaccination coverage among people who use drugs in Wisconsin to protect them from the consequences of viral hepatitis. And now Kailynn is going to walk us through how we can work together to prevent this in Wisconsin.
Thanks, Ruth. So before COVID-19, DHS began efforts to improve adult hepatitis vaccination. So for example, the Wisconsin Immunization Program created the Vaccine for Adults program, and local health departments can outreach to and provide on-site vaccination services in locations where people at risk might reside or utilize services such as jails, shelters, and SSPs, which are syringe service programs. Now, as we adjust to life with COVID, DHS is working with partners to develop methods of improving access to hepatitis vaccination for adults. These efforts are targeted to people who use drugs and SSP clients, and it includes programs to outreach to clients through non-traditional settings such as emergency departments and substance use treatment centers. So what can you do to protect people who use drugs from viral hepatitis? For your patients, you can look them up in the WER to assess their vaccination status. If you do not already have access to the WER, please contact them here, listed at the phone number or email on this slide. Also, individuals can look themselves up in the WER to see if they have been vaccinated. If they have already been fully vaccinated, then they are protected from Hep A and Hep B. So if they have not already been vaccinated, then we ask that you recommend to them that they be vaccinated. Please administer vaccinations to them if you can, or you refer them to another place where they can get vaccinated. If you administer vaccines, make sure you record them in the WER, and you can contact the help desk if you have any questions about how to do this. And Ruth, if you want to go to the next slide, that's okay. And the next one. We wanted to draw your attention to the new CDC outreach materials that are available in poster and social media updates. They have a specific focus about people who use drugs getting vaccinated for hepatitis A and hepatitis B, and we have 3 different examples to show you. So because there is no vaccine for hepatitis C, the best method of prevention is to educate people who inject drugs about safer injecting practices, including not sharing equipment used to prepare or inject drugs with others. Syringe service programs called SSPs also provide important services like sterile syringes, equipment, and disposal of used equipment. They also provide overdose prevention education and naloxone distribution for their participants as well as their surrounding communities. They provide referrals to substance use disorder treatments. They provide screening, care, and treatment for HIV, as well as screening for hepatitis C, and sometimes also STIs as well. And they provide safer injection practices, abscess and wound care as well. And lastly, they're a great referral source to social, mental health, and other services in the community that the participants may be in need of. Many community organizations provide SSP services, and one of them includes Vivint Health, formerly known as AIDS Resource Center of Wisconsin, and their locations are shown here on this map. In addition, some local health departments and tribal health clinics in Wisconsin also provide SSP services to their communities. So recommend and administer routine and catch-up vaccination for children and adults is very important. But there are COVID-19 implications for vaccination. So vaccination rates decrease during the safer at home or shutdown, but offices are reopening and adolescents and children should be receiving routine vaccinations as normal. But please call your provider and check with your clinics. Local health departments are at capacity working with COVID-19 patients and outreach, so vaccinations may be happening less. SSPs right now are only open based on appointments. And so this is meaning that less testing is happening, so less reminders to participants about recommended vaccines are being said to those people who use drugs. So that's just something to keep in mind. We wanted to provide you the updated hepatitis C testing recommendations through the CDC and also the United States Preventative Services Task Force. So who should be screened for hepatitis C? All people age 18 and older should be screened at least once in their lifetime. All pregnant people should be screened during every pregnancy, and this is a big change from previous screening recommendations. All people with certain conditions, including people living with HIV, should at least receive a one-time testing. And then people with ongoing risk factors, including people who inject drugs or use drugs, should have routine periodic testing. We generally recommend for our outreach sites to do at least every 6 months if they have ongoing risk. And then our general hepatitis reminders are also located at the source below. But essentially, people who use or inject drugs should be vaccinated against hepatitis A and hepatitis B. So that's why those reminders and referrals, or if you're able to vaccinate, are so important. And then people who use or inject drugs should be tested for hepatitis B and hepatitis C because most people don't know if they're living with hepatitis. So essentially, the big message is don't wait to vaccinate. People who inject drugs are at higher risk for hepatitis A and hepatitis B, and protection is prevention. Our contact information is on this slide. Ruth Koepke, again, is our hepatitis C epidemiologist, and then I am outreach and surveillance and harm reduction, and then Sarah Bourne is our hepatitis B epi and nurse.
Thank you all for that very thorough look into hepatitis A, B, and C and vaccinations. I do invite anyone who does have questions to go ahead and send them through. There were a few that came through during the presentation, one of which was, I thought it used to be closer to 75% of people infected with hepatitis C that developed a chronic infection. Has this number changed as we have collected more data?
That's a great catch. Yes, recent studies show that it's maybe more closer to 50%, but you're right. The old studies used to say 75% 5% of people who were newly infected with hepatitis C developed chronic infection, but more information has been collected on that. So great catch. But it's still sort of unclear, right? Who is going to become chronically infected and exactly what proportion of people will become chronically infected. Thanks for pointing that out, Abby.
Thank you. And then are there specific marketing and outreach efforts outside of SSPs in order to inform persons who are at risk of hepatitis A and B of the importance of vaccination?
As far as I know, I don't believe we have any specific marketing or social media strategies right now for that. It really would be up to the private healthcare organizations to put posters up and have that type of that media outreach messaging to their patients. But we do plan as DHS as a group to promote this messaging and our updated screening recommendations in 2021, some type of social media plan. So, and Sarah, feel free to chime in if you have anything additional about the Vaccines for Adults program or local health departments, but that's as far as I'm aware, or Ruth, if you have any other input.
Yeah, this is Sarah. I would just say that local health departments in Wisconsin do have the ability to provide those vaccines to adults, and some are more actively, I should say pre-COVID, were more actively engaged in that outreach in the community. I think currently, given COVID, that work is not very active at the moment, but health departments do have access to vaccines for adults and can provide that to them.
That is a strategy too of our hepatitis program at DHS. That's something that we're looking into to promote this messaging overall, and especially to substance use treatment centers or MAT and SSP places that can refer out or see those clients more regularly than a normal healthcare system might. Our FQHCs as well, when we do outreach, we're trying to remind them to push that messaging out to their patients.
And then a follow-up question from that, what is the eligibility for community members to receive vaccines from the Vaccine for Adults programs?
This is Sarah. I can answer that. So it is similar to the Vaccines for Children program in that the adults would need to be or underinsured. And then there are, for some vaccines, certain risk criteria that go along with it. But the primary indicator is that they do not have the insurance to receive those vaccines at a traditional healthcare institution.
Thank you, Sarah. And then it may be too soon to know, but have the syringe service and needle drop box programs helped to decrease the presence of hepatitis? Or I guess, do we know that?
That's a good question. We know from other studies of syringe service programs that there are many benefits to them, that they do reduce the risk of contracting HIV and hepatitis C and other infections associated with drug use. They also, by, as you said, taking back syringes, they reduce the amount of syringes in the community. And I can list off a number of ways that syringe service programs have shown in like a controlled study to be very effective. And Wisconsin as a whole, our hepatitis C rates, oftentimes states will be like, hey, your hepatitis C rates among people who inject drugs really aren't as high as they are in other states. And I've heard many people in Wisconsin who've been working on hepatitis C and with people who inject drugs in Wisconsin say it's because Wisconsin has had syringe service programs since the 90s. I think it was 1996 is when we started having syringe service programs. So while rates have been going up, we can't really say that that we've demonstrated within the past few years that having syringe service programs reduces the risk, but there is a large body of evidence that syringe service programs are effective in reducing the risk. And in Wisconsin, we probably have lower rates in general than other states that don't have syringe service programs. So I hope that answered that question. I don't know if you had anything to add, Kailynn.
Yeah, so I was going to say another benefit of our longstanding SSPs across our state is the way that they're able to refer their participants to other social health services in the community. So it's not always just about exchanging the syringes or equipment. A lot of times it can be setting them up with a food pantry or like some type of housing assistance or getting a job, like job assistance, unemployment assistance, referring them just to general healthcare providers in the area that they know are welcoming of people who use drugs and will have that comfortable fit for those participants. Some of the sites do have a clinic attached to them. So if they were someone living with HIV as well, they're able to utilize those clinic services. So yeah, I encourage you all, if you haven't taken a look, the CDC has a specific uh, section. You can just Google CDC SSPs and it'll come up with, they have multiple fact sheets and FAQs about the benefit of SSPs across the nation and how it reduces HIV and hepatitis infections, as well as increases people seeking out treatment services, getting into recovery and being treated or getting connected to care for HIV and starting medication and just taking better care of themselves. So it's really a holistic harm reduction approach that they take.
Fantastic. Thank you, Kailynn and Ruth. The next question we have is, can you elaborate on how you have been working with the emergency departments to increase vaccination?
I can start, but Sarah, feel free to jump in. So this was a pre-COVID-19 plan for us. When the Hep A outbreaks nationwide were happening, we developed an internal Hep A incident management command, just trying to prevent a Hep A outbreak in Wisconsin and to get all our partners at the table and increase our collaboration. We already work very closely with each other at DHS, so that's a really good benefit for our state health department. So by developing that, one idea we had was increasing that messaging and ability to vaccinate at emergency departments. So it hasn't really begun, but that is still what we plan to do in the future. Obviously with COVID-19, hospitals and healthcare staff are pretty overwhelmed. So just trying to navigate what's the best way to do that and not overwhelm people. And Sarah, if you have any additional input from the immunization program, feel free to jump in.
I don't have anything to add. I think you answered it well.
Great. So the next question we had come in was, what do you recommend for our community members that would be good candidates for hepatitis A and hepatitis B vaccine, but have badger care? I'm specifically thinking about people that don't have a primary care provider that they see.
This is Sarah. I can start. So I assume you're talking about adults, correct, that have badger care? Because children with badger care would qualify under the Vaccines for Children program and be eligible to receive vaccines. If they are an adult with badger care, unfortunately, it does get a little bit more complicated in that, yeah, they slip through the cracks. It does get a little bit more complicated. And traditionally, they would be directed to their healthcare provider. Most health departments don't have the ability to provide the vaccine to adults with badger care. There may be certain, exceptions to that or certain special projects where that's an exception, but yes, that is a challenge. I don't know if you guys have any more to add.
Yeah, I was going to say another suggestion would be knowing who takes Medicaid patients in your area and maybe trying to connect with some healthcare providers at those systems. So what comes to mind to me is a lot of FQHCs, federally qualified health centers, might be able to vaccinate those patients and possibly reaching out to maybe your local pharmacies and seeing if they're able to bill badger care and provide those vaccines. I know one reason why the recommendations were updated were to potentially make the vaccines better covered for patients. And Sarah, if I'm incorrect about that, but I think by changing the recommendations, it should lead to more insurance coverage, hopefully, for these adult patients. So yeah, I would definitely reach out to if you have any of those local free clinics or federally qualified health centers, because usually they can serve that population if the health department is unable to.
Sarah, would they be able to just walk into a pharmacy if they had Badger Care and ask for vaccination, or no?
I'm honestly not sure. I think it might depend upon the pharmacy and what sort of billing mechanisms they have set up.
Gotcha. Thanks.
Yeah, if you, I know in Madison, we have a community pharmacy, so maybe that could be something to look into if you have a local area community pharmacy. I know sometimes they can help as well versus maybe like a big chain. But yeah, if people need specifics about that, like for your region, feel free to email us and maybe we can help look into it more, facilitate conversations or something. But yeah, definitely the adult population with Medicaid is missed through the cracks. So, and that's usually who, you know, is more at risk, who we'd like to see being vaccinated.
Thank you. I don't have any other questions at this time, but if anyone has any remaining questions, we do have some extra time. I'm glad we've had this much time for questions. They've been great ones. I am going to put a link to our evaluation in the chat. I'll also be sending this through to everybody in an email following on from this webinar. That email will also have the form that anyone looking for nursing contact hours will need to complete and get back to us. So that'll be coming with that email as well. But if there aren't any other questions, I just want to thank Ruth, Kailynn, and Sarah for the very informative presentation, answering all those questions. I think people took a lot away from it. And with that, I think I will let you guys all enjoy. Hopefully everyone's having a sunshiny day here. So thank you all for being a part of today's webinar.
Thank you.
Thank you.
Thank you.